A 32-year-old woman walks into the emergency department with sudden onset breathlessness. Her oxygen saturation is 96%. Her chest examination is almost normal. Her chest X-ray is also normal, and ECG shows only sinus tachycardia. This patient is diagnosed as a patient of anxiety and sent home. 2 hours later, she collapsed. The diagnosis was pulmonary embolism. So friends, in today's video, I am going to tell you how not to miss pulmonary embolism in a patient of breathlessness who seems to be normal. Whenever a patient of breathlessness enters into ER, most of the doctors they think about either asthma, COPD, pneumonia or heart failure. But the dangerous condition of PE, it often hides behind the subtle findings. Here many times you will have a normal chest examination, the X-ray will also be normal, and sometimes there will be no chest pain. But what will work here? Your diagnosis, it will depend only on the clinical suspicion. Now we will see step by step how to go for the diagnosis of pulmonary embolism. So whenever such patient comes to your hospital, your first step will be you have to think, could this be a clot? So think about pulmonary embolism if there is sudden breathlessness, pleuritic chest pain, unexplained tachycardia, syncope, and hemoptysis. And hemoptysis is less common. So if the symptoms have developed within minutes or hours rather than days, then pulmonary embolism must be in your differential diagnosis. So now your second step will be you will look for the risk factors for pulmonary embolism. So these are some common risk factors like recent surgery, immobilization, long travel history, cancer, pregnancy or postpartum condition, history of OC pills consumption, previous history of DVT or pulmonary embolism, obesity and smoking. So if these risk factors are present, there are high chances of pulmonary embolism. But one important thing is that about 1/3 of patients have no obvious risk factors. So if there are no risk factors, you cannot rule out pulmonary embolism. Now your third step will be you have to do a SMART examination, because in case of pulmonary embolism, these will be the findings which will be very confusing. There can be tachycardia, tachypnea, there can be a little of hypoxia also, and if you auscultate, most of the time you will get clear lungs. And important finding you will also have to see is about examination of legs for DVT. Here you can get calf swelling or tenderness, unilateral edema or increased calf circumference. In this picture, you can see that on the right leg, in the right leg, you can see these signs of DVT. So your important third step will be SMART examination. Now, what investigations can help you in the diagnosis of pulmonary embolism? So these are some investigations. In ECG, you will most of the time will get sinus tachycardia, a classic sign of S1 Q3 T3. This finding is very less likely. Then X-ray chest will be most often normal. In ABG, you will get hypoxemia and respiratory alkalosis. And if echo is done, you can get right ventricular strain on the echo. Now, two important investigations that will help you to rule in or rule out pulmonary embolism. First is D-dimer. D-dimer rules out pulmonary embolism only in low-risk patients. And if there is high clinical suspicion, then you have to go for CT pulmonary embolism. So this is a CT pulmonary angio in pulmonary embolism. So here you can see a saddle thrombus. This gray color, you can see here it is a thrombus, and due to the presence of thrombus, the pulmonary trunk has become dilated. So this is CT pulmonary angio. So in the last slide, we have seen that if patient is low risk, then D-dimer helps to rule out PE. But if the patient is high risk, then you have to go for CTPA. So how you will decide if the patient is low risk or high risk? So for that, there are two important clinical prediction scores. The first is modified Wells criteria and the other is revised Geneva score. So in this criteria, it is Wells criteria, if the score is more than 4, then PE is likely, and if it is equal to or less than 4, then PE is unlikely. So if the score is less than or equal to 4, you will go for D-dimer, and if D-dimer comes positive, then you will go for CTPA. But if the score is more than 4, then you will directly go for CTPA. Now the problem with modified Wells criteria is that some criteria of this score are subjective, that is, other diagnosis less likely than PE. For that, you have to be little experienced. But if you are a new doctor, then this score, that is revised Geneva score, is better for you because here all criteria are objective. Now here, if the score is 0 to 3, then it is low probability. If it is 4 to 10, then it is intermediate. And if it is more than 11, then it is high probability. So if the patient comes in high probability, we will go for CTPA. And if the patient comes in low probability or intermediate score, you will first do D-dimer, and if it comes positive, then you will go for CTPA. So in this way, if a patient comes to you with breathlessness and most of the findings are normal and you suspect PE, then these are the steps how you will proceed. So take home message is that first you will ask, could this be a pulmonary embolism? Then if there are any risk factors, then you will go for a SMART examination, and lastly, investigation with the help of various clinical prediction scores. So keep in mind that you don't diagnose pulmonary embolism because CT scan tells you, but you diagnose it because you thought of it first. If you find today's video useful, give it a like, share with your friends, and if you have come for the first time on this channel, then do subscribe this channel for more such clinical videos. See you in the next video. Till then, thank you.